morning. I'd like to call the meeting of the Senate Health and Human Services Committee to order. It's Thursday, March 21st, 2024, and we do have a quorum present. First, we are going to take up Senator Mann's bill that we weren't able to get to yesterday, so Senate File 3511. Senator Mann.
Thank you, Madam Chair. Members, Senate File 3511 will make sure that all necessary prenatal care, maternity care, and postpartum care will be covered by insurance at no cost to the patient. Members, we have a maternal morbidity and mortality crisis in America. Maternal mortality rates in America, on average, about 23.8 deaths per 100,000 live births, and that number is a couple years old. It is now higher than that. White women are dying at 19.1 deaths per 100,000 and black women at 55. In comparison, the next country with the highest mortality rate is New Zealand at 13.6. Korea is at 11.8, France is at 7.6, the Netherlands are at 1.2 deaths per 100,000. So I will note also that the majority of these deaths in America, over 80% of them, are preventable. Recommendations to decrease the death of women in America include expanding Medicaid coverage to 1 year postpartum, which Senator Morrison did a couple years ago. Diversifying the workforce, which we are taking steps to do with bills such as the International Medical Graduate Bill. Increase access to midwives, which Senator Bolden is working on. And other recommendations include comprehensive reproductive health care access, which we heard Bill 3567 yesterday, which will do that. And comprehensive free or affordable primary and maternity care before, during, and after pregnancy, which is the purpose of this bill. Studies suggest that expanding maternity coverage can also reduce the high costs associated with preterm births and low birth weights. This bill seeks to take that next step so that we can continue to decrease the rates of maternal death and morbidity in Minnesota. With that, Madam Chair, I do have a testifier.
Thank you. And we have on Zoom Eileen Crespo. And if Dr. Crespo, if you can state your name for the record and begin your testimony. And thank you for joining us again today.
Thank you so much. Good morning, Madam Chair and members. My name is Dr. Eileen Crespo. I have the honor of serving as the president of the Minnesota chapter of the American Academy of Pediatrics. Our chapter represents over 1,000 pediatricians in the state. Our mission is simple. We advocate for the health, safety, and well-being of our patients, Minnesota's children. I'm here to testify in support of Senate File 3511. There are many items in this bill that are critical to ensuring access to care for newborn infants and their birthing parent. But as a pediatrician practicing in Minnesota for nearly 30 years, I want to focus my testimony on the section in the bill requiring coverage for the transfer of a birthing parent, newborn, or newborn siblings to a different medical facility when one of them requires a medically necessary transfer. This section of the bill is extraordinarily important to the health and development of newborn infants who may need additional care postpartum. No infant should be separated from their birthing parent at this stage. Bonding between the parent and infant begins immediately and is likely even more critical in cases where an infant requires additional care. There is overwhelming scientific evidence that touching, smelling, and cuddling infants causes hormones to be released that help bond infants to their families, and physical touch helps improve breastfeeding success. There's also excellent data that skin-to-skin contact, otherwise known as kangaroo care, for all infants, but especially for critically ill infants, helps decrease stress, helps stabilize body temperature, and regulate their heart rate and breathing. Regulation of heart rate, breathing, and even blood sugar as a result of decreased stress has been shown to decrease hospital stays for critically ill and premature infants. Of course, this cannot happen when the parent and baby are separated. I appreciate the opportunity to testify on Senate File 3511, and I'd be happy to help answer any questions.
Thank you. That is the only testifier we have. Members, do you have any questions or comments? Senator Morrison.
Thank you, Madam Chair, and thank you, Senator Mann, for bringing this just really important bill forward. You mentioned the maternal mortality crisis in the United States. It's worth repeating that we are an absolute outlier in the developed world, not even close to our peer nations. And there are a lot of reasons for that, but lack of access to affordable health care for low-income communities and communities of color in the United States and in Minnesota is a piece of that. You know, a maternal death is an unbelievably devastating event, obviously for a family. The ripples through a community and frankly through an entire state cause generational harm. A single one is not acceptable, and when you consider that 80% of them are preventable, we have to do better. You know, we're seeing in the wake of the Dobbs decision in states that have banned abortion or restricted access, we're seeing providers now not agreeing to see patients until they're past the first trimester because they're afraid of the uncertainty in the law. The first trimester is an incredibly important period for patients to be educated about things they can do to have healthy pregnancies. So to not have access to care in that first trimester, and ideally preconceptually as well, is very dangerous. So I don't have a question, Senator Mann, but I want to thank you and salute you for taking this effort on. It's just incredibly important.
Thank you. Any other member questions or comments? I see none. Senator Mann, do you have any final thoughts?
No, Madam Chair. Senator Morrison summed it up beautifully.
Thank you, and thank you for bringing the bill forward. It is, I think, really important for us to focus on these aspects of maternal health and especially the transport part. It just makes sense that we allow parents to be together with their newborns. With that, we will be, Senate File 3511 is laid over for possible inclusion in an omnibus bill. Next, we will go to Senator Marty, Senate File 3543.
Thank you, Madam Chair and members of the committee. Senate File 3543 is a simple bill. It basically undoes a decision that was made in 2017. Minnesota, until that time, only did not allow for-profit HMOs to operate in Minnesota. And in that time, it was decided that maybe we should add them to the mix in Minnesota. And the concern here, my concern with that decision, the reason for going the other direction on it is that you look at the purpose of how our HMOs in Minnesota had been organized as nonprofits with their interests, their requirements under our public interest law to serve their members, serve the public, not to earn a profit. The for-profit corporations that came in or are coming in with this are ones who the only way they can make money for their shareholders, which they are required, their fiduciary obligation is to their shareholders. The only way they can make more money for them to maximize that return is by either charging more or delivering less care. Neither of those are things we're trying to look for in our healthcare system as we try to hold down costs and improve care. And I think there's been plenty of evidence around the country that that for-profits, whether they're operating as HMOs or whatever, that they have been driving up the costs. They've been making a lot of money on public programs. And so I think that this is a public interest that we reverse this. The bill is very simple. Most of the bill is just changing it. Right now it allows foreign or domestic corporations, and we would be restoring it to the old language of nonprofit corporations organized under Chapter 317A. And that's basically all of the sections of the bill except for there's a transition in Section 7 that deals with how we phase out of our current system, because there are 3 for-profits that have a small share of the market right now, but they would not be able to sell or offer, renew any contracts after August 1st, and then they would have to notify their members that they would be out of business at the end of 2025. And with that, Madam Chair, I'm happy to stand for questions.
Thank you, Senator Marty. And you do have, there's an amendment to fill in, I think there are a couple blank spots and a couple dates that are added. Senator Mann moves the A1 amendment. And all those in favor, please signify by saying aye. Aye. Any opposed? The A1 is adopted. And there is a testifier sign up, Michelle Benson. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair. I'm Michelle Benson, representing the Health Plan Partnership of Minnesota. Members include Cigna, Allina Health Aetna, and United Healthcare. And I will say, Madam Chair, this is not the first time Senator Marty and I have discussed this issue. Thank you for allowing me to testify. Last year, the legislature requested a report on HMO conversions. This report was to be released in two parts, February of 2024 and June of 2024. As the committee considers Senator Marty's bill, please note a statement from the executives in that summary. Minimal data are available to shed light on whether differences exist between nonprofit and for-profit HMOs with regard to day-to-day operations, enrollee satisfaction, and the quality of care. It's on the page, second page of the executive summary, members. And you'll notice tabbed throughout the report are comments that there's simply data not available. That data should be available in June. All HMOs, regardless of status, are subject to Minnesota Department of Health and Minnesota Department of Commerce regulation. They are subject to medical loss ratios. They must offer strong provider networks, competitive rates, and must successfully serve enrollees in order to retain enrollees. They must competitively bid for public programs. In 2017, after extensive debate, a law was signed by Governor Dayton to give consumers and employers more choice. Incorporated in that law was not just a for-profit provision, but a change in the definition of small group markets and the expansion of co-ops to allow them to serve farmers, giving Minnesotans more choice. That was the purpose of the 2017 law. This would give Minnesotans the best value options for their coverage. No HMO can charge more or provide less in a competitive market. HMOs, regardless of status, are subject to medical loss ratios at the federal level and the state level. Any excess funds, that is, any excess funds are required by law to be returned to enrollees. Additionally, MDH gathers information on the 1A report to ensure that only allowed expenses are included in the cost attributed to public programs. Many of you remember a few years ago when a health plan exited the market, and it caused chaos for MA enrollees. They had to go through a reassignment process, and the Department of Human Services will tell you it was hard on those enrollees. HMOs, regardless of their status, are part of complex organizations, and I hope as you review this study, you'll note Appendix C, where it demonstrates that HMOs often have for-profit affiliates, regardless of the nonprofit status of the parent organization. The report coming in June will shed more light on the HMO market and demonstrate the similarities between for-profit and nonprofit HMOs. The Health Plan Partnership of Minnesota opposes Senator Marty's bill with all due respect, as we are community partners, employers, and are dedicated to giving value and health coverage to Minnesotans. I thank you, Senator Marty, Madam Chair, and committee members.
Thank you. Members, do you have questions or comments? Senator Udke.
Madam Chair, would you like me to stay for questions, or they be directed to Senator Marty?
If you want to just stay close by, then
I'll stay close by.
we'll
Thank
be
you.
available. Thank you. Senator Udke.
Thank you, Madam Chair. And my first question was, Senator Marty, you mentioned there's 3 of them. I'd like you to name those. Could you, please?
Madam Chair, I
Senator
believe
Marty.
one is United Health Care of Illinois. I think another one is Allina Aetna package, and I can't remember who the third one is, and I'm not sure if the third one is operating yet.
Senator Udke.
Okay, thank you, Madam Chair. A number of the things that I was thinking of and was going to cover Michelle Benson just covered for us, so that was great. But the one thing that always drives me crazy when we start to drive, this nonprofit versus for-profit, they're all in the business of providing the same thing. They have to make some money or they can't stay in business. If they're a nonprofit, they're just accounted for with different names. So they have to make money, they have to have reserves, or they're not going to be around. They're not going to be able to pay the claims when people use the services or go to the doctor. To me, this is, I won't say what I want to say, but I just don't like it. It's bad policy. We should leave it as is. We're going down the wrong road here, and I would hope that we don't have to see this get passed, so thank you.
Madam Chair?
Senator Marty.
Yeah, thank you, Senator Utke. A couple comments. One is that there's a difference in what amount of money people need to keep their business afloat. A nonprofit does not need to return money to shareholders. A for-profit is obligated. Their obligation under law, they can be sued if they are not trying to maximize their shareholders' rate of return. That's a totally different incentive, totally different interest, and frankly, the for-profit corporations providing health care have done a very good job under public programs. In the Medicare Advantage field, that's where they're making big money right now when they're losing on their fully commercial market. A couple of years ago, they were losing money on the commercial market and they would have been underwater except for the fact that they were making such profits on the public programs. To me, the medical loss ratio is a stopgap to stop some things, but Minnesota, our health plans made $2/3 of $1 billion a couple of years ago on our public programs. That's a lot of money. And to me, we want to make sure Minnesota has always focused on trying to maximize the well-being of the patients and making sure they get the best possible care. If you look at the number of prior authorizations required, the number of denials of care under for-profit HMOs, it's been significantly higher across the nation, and I think that's the same concern here. We have had a decent system in place. It's not the way I would do it, but it's a system that's worked. But we added them in because somebody said, hey, allowing somebody to come in whose number one interest has to be their shareholders is going to somehow improve the system, and it doesn't. It's taking money away from health care.
Other member questions or comments? Senator Mann.
Thank you, Madam Chair. So this idea of a free market or a competitive market in healthcare is a completely false narrative, right? And I've said this before and I'll say it again today. When people need healthcare, they don't go shopping for the best deal. So we're not buying cars here. And we know that this free market healthcare idea with competition doesn't work. We have the most expensive healthcare system in the world, and we don't have the healthcare outcomes to show for it. So healthcare is not a luxury. It is not a choice for many people. And like Senator Marty said, when there is a difference between making money to offer services and making money for a profit off of the back of sick Minnesotans. And so healthcare should not be for profit, period. And so thank you, Senator Marty, for bringing this incredibly important bill forward.
Thank you. Any other comments or questions? Well, I appreciate Senator Marty. I don't have any specific questions right now, but I appreciate your bringing the bill forward. I do think that there is a difference between, what's needed to run a business well and some of the needs of a for-profit entity. And I think our state goals should be met with, seeking out those who have the interest of Minnesotans, and we need to be the best stewards of our financial commitments to the state. And so Senate File 3543, as amended, will be laid over for possible inclusion in an omnibus bill.
Thank you, Madam Chair and members of the committee.
Thank you. Next, we will take up Senator Dibble, Senate File 4524. welcome to the committee Senator Dibble, and I believe that there is an author's amendment that's being passed out right now, so wanted to let you know that if you'd like to give us a little introduction to the bill. I guess the A1 is a delete everything amendment, so actually, why don't we adopt that so that you can present your bill as you intend. Senator Mann moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 is adopted. Senator Dibble.
Well, thank you, Madam Chair and members, for the opportunity to present Senate File 4524. I'd also like to thank my co-author, Senator Dietzig. Madam Chair and members, when the medical cannabis bill and program was first passed and established, it was properly subject to many constraints, which had the net effect of placing some fairly high barriers of access for a lot of people seeking relief from the symptoms of many chronic or ongoing conditions. Some of those barriers were, of course, the fees, the necessary re-enrollment every year, continuing justification for access to medical cannabis, needing to maintain ongoing cooperation and participation from their providers as well as their providers' systems, the prices, the availability of locations, the fact that there's no insurance available. A lot of these barriers still exist, of course. We've taken some steps, however, to address some of them. But now, Madam Chair, we, of course, have seen, and we have the advent of the adult use market, and so the lid has been lifted, and anyone who wants to access cannabis, marijuana, can just go to a dispensary. Except, Madam Chair, of course, that's not really the medical model, and when I stepped forward to pass medical cannabis, I was asked often if I wasn't just offering a pretext for clearing the way for full access for other purposes, to which my response was an adamant no. In fact, the early days of my political work and growing awareness of how policy intersects with our lives was around this very issue of gaining access for people to cannabis and cannabis derivatives, because of course I came out of the movement trying to fashion a more compassionate and thorough response to those who were struggling with HIV/AIDS, and many of my friends were accessing marijuana on the illegal market, not knowing what they were accessing, breaking the law, et cetera, to gain relief from symptoms that they were suffering with. So I really believe, Madam Chair, that the medical model continues to add value and really is what people who are suffering are going to continue to need, especially children who suffer from an array of seizure disorders who need to continue to access a fairly sophisticated concentrates and derivatives, particularly around the cannabidiol derivatives, as well as delivery substances and mechanisms that allow for filtration, et cetera. Others need relief from the symptoms from which they suffer with different kinds of concentrates and formulations and blends without the intended intoxicating effects which they don't desire. So, Madam Chair, this bill is an effort to keep the medical model strong and economically viable so that it can remain in place and be an important option for people. It eliminates one of the key accesses, one of the key barriers of access, which is one of the mechanisms, one of the gates that is in place now, a decision on the part of the commissioner of what gets in and what doesn't through a deliberate methodology. That falls down under a number of analyses. Probably first and foremost is that those who don't get through that process can just simply go to a dispensary and just take their chances, buying whatever might be available there that day. It does maintain some of the key benefits, some of the values that the medical model brings. I talked about the formulations, but there's also the continuing consultative model with providers as well as the pharmacists who are the actual prescribers on site, gathering data for research and more. The bill also, Madam Chair, in conversation with the Department of Health, identified a number of implementation pieces which don't necessarily need to be picked up in the bill, but one thing they did identify was access for veterans, particularly those who are getting their health care through the VA, which is subject to a lot of the federal constraints in the federal laws, which of course we know we have to do all of this work on cannabis, whether it's adult use or medical use at the state level. There are a lot of constraints in the federal system, and the VA is subject to all those federal constraints. So it creates a path for veterans to gain access to medical cannabis in Minnesota. Ultimately, Madam Chair, I will acknowledge this is not ideal. This is not what we want. We want medicine to be medicine. We want there to be good research and people to just be able to go to their doctors and their pharmacists and get what they need and not have these various islands around the states. But the problem there, of course, is the catch-22 that we're in with cannabis and marijuana being a Schedule I drug. It doesn't belong as a Schedule I drug, but it is, and it's been really, really hard to dislodge off of that spot on the controlled substances schedule. And so that is a huge constraint on federally sponsored and funded research done by, far and wide, et cetera. So we're doing the best we can with the kind of system we have in this country. Someday, the benefits of cannabis and its derivatives will be widely recognized, and the silliness of it being on Schedule I will be eliminated, and people won't be forced to, by hook or by crook, get what they need through this model. I wanted to say that particularly when it comes to children suffering from seizure disorders and forms of epilepsy, something we discussed a lot. I think it was actually what really allowed us to pass the bill because the circumstances are so dire, and the traditional forms of treatment through the traditional doctor, patient, and pharmaceuticals that were available provided very little relief and many, many side effects that made their conditions in some cases even worse and made their quality of life extremely poor. Very, very heartbreaking stories, and we've seen just miraculous turnarounds in these young people who have been able to access these cannabidiol derivatives that we now have in Minnesota. So with that, Madam Chair, I don't know if anyone's here to help me testify. I know my proponent was caught up in a bill hearing on the other side of the street, but I could probably handle it if no one's here to. Maybe online?
I have someone on
okay.
Zoom.
All right.
Timothy Casey. And Mr. Casey, if you could state your name for the record and begin your testimony.
Well, hello, Chair Wiklund and members of the Health and Human Service Committee. My name is Timothy Casey. I'm one of the pharmacists that currently work in Minnesota's medical cannabis program, and the author of the petition that was accepted by the OMC in 2023 to get dry herb vaporizers as an approved consumption method in the program. I am here today in support of SF 4524, the Physician's Choice Bill. I think there are two main reasons for supporting this bill. The first reason this bill should be passed is that it will reduce patient confusion. I've experienced many patients that have come into the program much later than they would have otherwise, except for that they had incorrectly excluded themselves from the program, not realizing that their condition would in fact qualify. An example of this is when I recommended a friend of my parents to talk to their physician about joining the program for diabetic neuropathy. He correctly pointed out that diabetic neuropathy is not an approved condition, and I then had to explain that diabetic neuropathy would qualify under chronic pain. I am convinced that if I wasn't a pharmacist in the program and there to convince him to talk to his physician, he would still be self-excluded from the program today. I believe there are many patients like him that would be interested in asking their physician, but don't out of a misunderstanding born from having a limited list of certifiable conditions with no additional context. The second reason this bill should be passed is philosophical continuity. With the adult use bill that was passed last year, you as a legislature and us as a state came together and decided that adults in Minnesota should have access to cannabis with or without a recommendation from their physician. Other states with adult use programs, particularly Maryland, Colorado, Massachusetts, and Missouri, have followed this line of thought. In a state that has adult use cannabis for sale, patients' access to medical cannabis should be prioritized. I do not see how it makes sense for a government agency to decide for a physician whether their patient's condition or symptoms would be benefited by cannabis or not. This determination should be made based upon the physician's best judgment as a medical professional. It would be awfully bizarre to me if someone like my mom could walk into an adult use dispensary and buy a product at the recommendation of her physician, but not necessarily be able to walk into the medical dispensary I work at and buy that same product with that same recommendation. In order to make things clear for patients and physicians and to just stay philosophically consistent, I ask that you vote yes on this bill. Thank you.
Thank you very much for your testimony. Members, do you have questions or comments about the bill? Senator Utke.
Thank you, Madam Chair. Questions here for Senator Dibble. As I see it now, with the qualifying medical conditions, it's anything a doctor would recommend would be available at this point, because going to page 3 of the amendment, we're taking the commissioner out of any of the decision-making as far as what qualifies for as a medical condition. So am I reading that right, that right now a medical provider would be the final stop?
Senator Dibble.
Thank you, Madam Chair. That's the crux of the bill, yes, Senator Utke. To the point that I made earlier, as well as our testifier, anyone can walk into, what we will see around Minnesota, just a regular adult use dispensary, and access this very similar product. So at least we will maintain the medical model under what we have already, under this proposal, and allow folks to come into a medical dispensary, working in conversation with their doctor as well as the pharmacist we heard, to try to more precisely access what they need based on what conditions they present.
Senator Utke.
Thank you, Madam Chair. Because I don't know on this one, can you help? What is the difference between what they would get on the medical side versus the recreational side at this point? I can imagine what the recreational side entails, but wouldn't the medical have more specifics to variations? And if so, is this, I mean, shouldn't there be some guidance to the medical side?
Senator Dibble.
Thank you, Madam Chair. Senator Ecker, that's precisely why I want to maintain the medical model and not allow that side of access to collapse, because they have access to a lot of knowledge. There are pharmacists on site who are extremely knowledgeable, as well as, there's been now a body of evidence that's been collected over the years in Minnesota since we've had medical cannabis. They document who's coming in, presenting with what conditions and what the outcomes are, et cetera, and they continue that conversation back with their provider. And they can access, their oils and other forms of delivery systems, topicals and edibles, and now whole plant. But the plants, the flowers, there's a lot of knowledge about the strains and what balance of the different. There's 1,000 different chemicals in cannabis plant. Some of it is cannabidiol, some of it is THC, of course, but there's terpenes and all these things that kind of come together and have a combined effect in different proportions. And they have that knowledge. Some things work for chronic pain, some things work for seizure disorders. Some people really need to access a substance that's not intoxicating. And so so the guidance piece is still there. That's why I want this proposal to go forward, because otherwise people, won't wait for all the bureaucratic hoops to be achieved before their condition qualifies them to access medical model. They'll just walk into a store and get something that may or may not work for them without any, with someone who's not knowledgeable behind the counter, just selling them whatever looks good behind the glass case.
Senator Radke?
Thank you. That's all.
Other questions? Senator Morrison?
Thank you, Madam Chair, and thank you, Senator Dibble, for bringing this forward. I'm all for trusting medical providers' decision-making, and allowing them to use their medical judgment in creating treatment plans. I think we all know how I feel about prior authorization. But it strikes me as a little bit odd that we would say 0 prior authorization for medical cannabis when our data on cannabis for treating just about everything is weak compared to other data. But we'd have to do prior authorization for medicines like insulin. So that disconnect is a little, I'm trying to reconcile that. I'm wondering, does MDH have an opinion on this, or MMA? Have any of the medical kind of organizations weighed in on this effort?
Senator Dibble?
Thank you. It's a great question. I completely agree. The evidence is weak in a lot of areas because there is no good research because of the catch-22 of the whole research situation. Insurance doesn't cover any of this. This is entirely out of pocket. So I think the prior authorization and step therapy mechanisms probably don't apply here. So there's just no way to access any reimbursement through your healthcare insurance, healthcare coverage for any of this. So that's one of the big problems. Someday it'll be medicine and it'll be covered under insurance, and then we'll have another discussion about prior authorization.
Senator Morrison? Is it?
Thank you, Madam Chair, and thank you. Completely agree on the Schedule 1, and the lack of research is because of that primarily. We need to do a lot more research. Does MDH have a position on this bill?
Senator Dibble? There is someone who is coming forward. If
Senator.
welcome to the committee, and please state your name for the record. And
Thank you. Madam Chair and committee members, Chris Elverum. I'm the Assistant Director of the Office of Medical Cannabis at the Health Department. And I think this bill and this amendment reflects the current situation. I think we agree that there isn't a lot of evidence or a lot of information available about how it affects other conditions, and that's a problem. So we know what we know, and we don't know what we don't know. But the fact, again, that patients, if they choose, can just walk into a dispensary and get cannabis, what this does will at least preserve the consultation with the healthcare provider as well as the pharmacist on site, provide access to those specific things that are more common for medical patients than may not be in the regular dispensary. So yeah, in an ideal world, we'd have a lot of information. We'd be able to know what works for, what cannabis works best for, but just faced with the current reality, the department is just understands that this is just the way it's going to be. So we're neutral on the bill.
thank you. Senator Morrison?
Thank you, Madam Chair, and thank you. Appreciate that.
Thank you.
Thank you. Oh, and could you sign in if there's a sign-in sheet there? I appreciate it. Thank you. Senator Abler?
Well, thanks, Madam Chair, and Senator Dibble, I'm sorry I was late. I just have I think it's almost a moot bill in the first place. I think that the nice thing about the medical, because the people are going to get it everywhere, and at least this way, at least in the meantime, people that want to try something for their health purposes aren't going to get something laced with something horrible and die from what their friend got them. So in going at least, I didn't support legalization in the first place, and everybody knows that. I'm worried about the ill effects on minors and all, but at least this way people who want to try it are not going to be coming to harm. And I think further if you wanted to make all these things dispensaries for people that want to go buy stuff that they're certain is quality, they're up and running. So there you go. Thanks.
Any other questions? Senator Liskey?
Thank you, Madam Chair. Senator Dibble, I appreciate the purpose of the bill. I have patients that already have come to me, talked to me about stuff like this. they ask me, and of course I tell them, I don't have a position, I don't have any answers for you on what works, I can't help you with that, I'm not a medical doctor, I don't answer those medical questions. Then they said, well, what medical doctor does? And I go, I don't know that there is one right now that would be able to answer those questions, mostly because of something like this, right? We don't have the research, we don't have the answers. And so they go and they buy it themselves at wherever they get a hold of it, and they try it themselves. There's no answers, where I think what your bill is attempting to approach is that there's not going to be a workaround. They'll be able to ask for help. They'll be able to have an educated response, and hopefully that's what this is trying to do. So I appreciate what you're trying to do.
Thank you. Any other questions, comments? Senator Dibble, any final thoughts?
No, just thank you for the time and the great conversation. Appreciated all the questions and the input. And I really, really hope this works and helps maintain the medical model alongside the adult use model. I really hope it doesn't collapse because that would be, I mean, we don't know a lot about, the efficacy of medical cannabis. For a lot of things, we do know, and I was just doing my Googling this morning, especially on the evidence, and there's growing pretty solid peer-researched evidence on why and how the cannabidiol derivatives work for these children with the seizure disorders. And, the anecdotal evidence is, profound, but now the objective research-based evidence is becoming more and more solid, and I really hope we can maintain that. Thank you.
Thank you. Yeah, it does seem like there are specific people who could be helped and won't be able to access products through just the regular market. And I appreciate that by doing this, the doctor will have to talk about, what specific condition they might recommend. And then when the person does go to a dispensary with a qualified, pharmacist there, then they can talk about that specific condition and hopefully get directed to the type of product that really meets their needs. So thank you for bringing it forward. And Senate File 4524, as amended, will be laid over for possible inclusion in an omnibus bill.
Thank you, Madam Chair and members.
Thank you.
My next or my...
Are we going to the next bill? Senate File 2320. Okay. Senator Dibble.
All right.
And Senator Dibble, this bill also has an amendment. Is it your author's amendment?
Yes, Madam Chair.
And Senator Mann offers the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Dibble.
Thank you, Madam Chair, for the opportunity to present Senate File 2320. I wanted to thank my co-authors, Senators Umu Verbaten and Senator Bolden. Not sure if anyone else has come on the bill since then. I think there are. But anyways, this is a great bill because it allows people to access vital, life-saving HIV/AIDS prevention medications from their pharmacists. We have seen this step taken in many other areas, many other things that pharmacists are now allowed to prescribe/dispense, whether that's nicotine cessation, pharmaceuticals, vaccines, birth control, talked about medical cannabis in particular settings, of course, Narcan or naloxone. Madam Chair, members, we could end HIV and AIDS in Minnesota today if we wanted to, if we had the resources and we had the political will to do so. And we have an official policy to end HIV/AIDS in Minnesota. That is the official adopted state policy to end all new infections of HIV and AIDS in Minnesota. Because when people know their status, and if they're positive, they get connected to care and treatment and access their pharmaceuticals and can stay connected to that treatment, they can bring their viral load down to zero. It becomes undetectable, and they become untransmittable. They will not pass HIV on to anyone else. And when people know their status and their status is negative, we need to make sure that they have the means to remain negative. PrEP and PEP are virtually 100% effective. Instead, we have held steady at about 300 new cases per year. And I think something is coming around, if it hasn't already, that shows now for decades, around 300 new cases of HIV in Minnesota per year. And aside from the tragedy and human suffering that represents, and our failure to help those folks avoid HIV, this is very, very expensive. We know that over the lifetime of a patient, we can spend upwards of $500,000 to $1 million per patient. So you can do the math. We have over 6,000 active cases of HIV in Minnesota. So we need to do everything we can. We need to move heaven and earth to move that needle down. So this is one important step that we can take, which removes a barrier. And the reason it's effective is, of course, the ubiquity of community pharmacies that are surrounding us in our communities, the ability for people to step into a pharmacy and gain access to PrEP and PEP, have an important conversation with their pharmacists, and continue to receive the medication that they need to keep themselves safe. The incidence of new infections, of course, is not a surprise, disparate among different communities with higher incidence among communities of color. And so some of the barriers that present in accessing PrEP and PEP is a barrier of knowledge and awareness, and it's a barrier of just the rigmarole and the process of having to go to a doctor, and sometimes there's some cultural and other constraints in going to a doctor and talking about yourself in that manner and saying that you want to access PrEP and PEP, whereas it's a lot easier simply to just go into a pharmacist and do so. Madam Chair, I wanted to call everyone's attention to another element of the bill, which is on the back page, which would remove from prior authorization or step therapy any class of drugs that is used for the treatment or prevention of HIV/AIDS in our medical assistance, our Medicaid program in Minnesota, which is something that we have done. We did a few years ago when there was a threatened prior authorization and step proposal, and the clinical community and the HIV/AIDS community mobilized to talk about how unwise that step would be, and the commissioner issued an order to not do that, consistent with the law in about 20 other states, as well as the federal law in Medicare Part D. So that is slightly outside of the scope of the pharmacist access of preventative medication, but it just makes consistent our current practice in Minnesota, and aligning us with our current practice as well as what is recognized as really medically necessary. So with that, we have a lawyer who wants to testify, and I think we might have some other testifiers as well. Thank you, Madam Chair.
Thank you. Yes, welcome to the committee, Mr. Boyer, and if you could state your name for the record and begin your testimony.
Yeah. Good morning, Madam Chair and members of the committee. My name is Dylan Boyer. I use he, him pronouns. I am the Director of Development at the Aliveness Project, which is a community and wellness center for people who live with HIV and AIDS. I am a proud out queer individual living in Minnesota, and I have been living with HIV myself for 8 years now. Hearing the news that you are HIV positive can be a very overwhelming experience. And nearly every single day, somebody in Minnesota finds out the news that they are HIV positive. And there are 40,000 new cases of HIV each year nationwide. If we had a vaccine to prevent HIV, we would see these cases significantly decreased. But we don't have a vaccine, and it is very uncertain if and when we will ever get a vaccine. Fortunately, we do have something else. It's called pre-exposure prophylaxis, commonly known as PrEP. When taken as prescribed, PrEP is more than 99% effective in preventing HIV. 10 years ago, I began my journey to start taking PrEP to prevent HIV. This was not a simple decision for me. as I was still on my parents' insurance and I had to have difficult conversations about sex and HIV and other risk factors with my parents before getting on this medication. Also, because of stigma in clinical settings, difficulty finding a queer competent provider, cost, navigating complicated healthcare systems, I continued to put off the appointment, but eventually, 2 years later, I decided to make that PrEP appointment. I was too late. It was at that PrEP appointment that I found out that I was HIV positive. Had access to PrEP been easily available at pharmacies, I would have started PrEP treatment sooner prior to my HIV exposure, ultimately preventing HIV. I believe that we can get to 0 new cases of HIV in Minnesota. I want to thank Senator Scott Dibble for his hard work on this issue and for supporting our community. I want to thank you, members of the committee, for your time. I hope you join us in ending HIV in Minnesota. Thank you.
Thank you. Next, I have Jamie Swanson. Welcome to the committee, and please state your name for the record.
Hi, Madam Chair and members of the committee. My name is Jamie Swanson. I'm an HIV specialty pharmacist at the Walgreens Uptown Row. We serve over 1,500 patients that are on medications to either treat or prevent HIV. Frequently, I've had patients call our pharmacy before even talking to a provider about whether PrEP would be a good option. They share concerns such as affordability, tolerability, and also accessibility. Where can they go? What provider can they see? PrEP has been available for over 10 years now. We've significantly reduced one of the most significant barriers since its introduction, which is affordability. But still, 1 in 5 patients that are at risk of acquiring HIV were prescribed it in 2020. Many patients that I've consulted with for the first time when they're starting PrEP say that they've been thinking about it for months, sometimes even years. Think of all the times that they've been exposed to HIV in that time period before actually getting started on the medication. If we want to meet the goal of reducing new infections of HIV in Minnesota, we have to take a more proactive approach to immediately connecting these patients to the life-saving medications that exist. This bill will put pharmacists in a position to quickly act on getting HIV preventative medications in patients' hands much quicker. Allowing pharmacists to prescribe PrEP would provide another patient access point to receive the pre- and post-exposure medications that they need. I urge you to please push this piece of legislation forward and allow us to practice at the top of our profession. Thank you.
Thank you. And then last, I have Emma Sherman.
Hello, Madam Chair and members of the committee. My name is Emma Sherman. I am a sexual health educator at Indigenous Peoples Task Force in South Minneapolis. However, I'm here today to share with you my personal experiences and what I have personally seen while working in the field of HIV prevention and care. I started at my position a year ago on April 5th, will be my 1-year work anniversary, and April 10th will be the 1-year anniversary of when I was accidentally stuck by a syringe. That was a very scary time for me as someone who was new to this work, as well as all of the fear of potentially being exposed to HIV. However, I was lucky enough to know about a medication called PEP, post-exposure prophylaxis. It is a medication that is taken after a possible exposure to HIV, and it needs to be started within 72 hours of the exposure. It is a 30-day course of medication, and I had to go to the emergency room and spend several hours waiting to be seen by a doctor, have some tests, and be prescribed this medication. I was prescribed only a few days while in the emergency room and then referred to an infectious disease specialist doctor who would prescribe me the rest of the course of the medication. After the appointment, however, there was an issue with the prescription and it did not get sent to my pharmacy, and when I went to pick it up, it was not available there. I ended up having to miss a dose, which is very much not recommended and does increase your risk for then contracting HIV. Luckily, I was able to get in touch with my provider and get my prescription. However, at that point, it became an issue of cost and not an issue of availability. I was in between insurances, having just started a new job, and I was told that if I wanted the medication that I needed, it was going to cost me $5,000 out of pocket. I did not have $5,000 sitting around that I could spend on this medication. I was very lucky in that I was able to work with the hospital where I'd gone to the emergency room and get on a delayed billing cycle until I could get my workers' comp number to them. So I was able to get my medication. However, I know and have seen very many people who do not have that privilege, who do not have that ability, and would have to make the choice of will they pay for this medication? Many of them do not have the money to begin with at all. Many others, it will then be a choice between, am I paying my rent? Am I paying my car bill? Am I paying my insurance? Or am I getting this medication? Do I pay for those other necessities and test in a month and hope that I did not contract HIV? Or do I fall behind on my payments? Do I risk possible eviction or repossession and be able to have that peace of mind and be able to protect myself from HIV? If I had been able to speak with a pharmacist to get this medication, I would not have had to have spent hours waiting in the emergency room. I would not have had to contact my doctor going back and forth to get this medication. It would have been much simpler, kind of like a one-stop shop type of thing. And I have worked with people, I have had people come in to see me for testing, and as I'm talking with them about testing, I'm asking, kind of what brings you in? And they tell me, well, I was stuck last night, or I had a sexual encounter, a day or two ago, and I'm not sure if that person had HIV or not. I'd like to get tested. Well, it takes 3 weeks for our test to be able to read any HIV. Along with that, those people are in that 72-hour window to start on PrEP. So I do educate them and counsel them on the availability of PrEP and where to go to get PrEP. PEP, not PrEP, but where to go to get PEP. However, many of them do not have the time to sit in an emergency room and wait to see a doctor. They have busy lives, they have things going on. If they were able to stop in and see a pharmacist, it would take much less time. They would be able to make their work shifts. They'd be able to pick up their kids from school. So this is a very important bill to increase access to these medications, PrEP as well as PEP. They are extremely effective and they are very much needed. As Dylan mentioned, there are 300 new cases of HIV in the state of Minnesota, and I just think how many could have been prevented if it had been as easy to see your pharmacist and get these medications. And the answer is all of them. So I would very much appreciate your support in pushing forward this piece of legislation. Thank you.
Thank you very much. Members, questions or comments about the bill? Senator Morrison.
Thank you, Madam Chair. Sorry, I'm chatty this morning. Senator Dibble, thank you for bringing this bill forward. This, unlike the last one, we have excellent data to support the use of PrEP and PEP. They're kind of miraculous, actually. And I thank you for including this information about current cases and also distribution of cases. This is a statewide challenge. This is in every corner of Minnesota. This is such a no-brainer to me. I strongly support this effort. There's whatever we can do to decrease barriers to prevent is for the good. Thank you, Senator Dibble. And thanks to the testifiers, too, so much for your testimony.
Senator Dibble.
Thanks. I know it wasn't a question, but I did want to respond. My testifiers kind of filled in the gaps of things I left out, so I'm really grateful to them. And just wanted to mention that it has been shown now in other places that have taken this step, two things that are important to know. One is the reduction in cases, particularly for those who are able to access PrEP by injectable means. There's two different modes. You can take a daily pill, or you can get an injection that then would be renewed just every few months. As you can imagine, much, much more effective, rather than having to remember to take that pill every single day. And so the rate of new infections has gone down, as well as, and part of that is attributable to the fact that more people, to the very powerful testimony that was provided, become aware and have access, because those barriers are reduced, particularly in areas outside of cities and also among communities that otherwise aren't accessing because they don't know, or they're not prescribed, or they don't have that connection to the provider community that a lot of us take for granted. So it's shown to be just a tremendous, tremendous step forward.
Thank you. Members, any other questions or comments? No? Well, I appreciate your bringing the bill forward. I had a meeting with pharmacists on their day on the Hill a few weeks ago, and they were very enthusiastic about supporting this, and really felt that there were some who were from the pharmacy school and others who were in training, and they felt that they would like to be a resource, as Ms. Swenson, as you say, that people, when they visit a pharmacy, and much easier access than maybe some other providers. So appreciate your bringing the bill forward.
Can I make one final comment?
Senator Dibble.
I'm glad you raised. Pharmacists are very enthusiastic, and the Board of Pharmacy is very supportive, and they stand ready to develop the protocols and the training and everything that needs to accompany taking this step.
Thank you.
Thank you.
And with that, Senate File 2320, as amended, will be laid over for possible inclusion in an omnibus bill. Next, we will move to Senate File 3926. Senator Hoffman.
Thank you, Madam Chair. Thank you, Madam Chair. I just had to have a little joke with Scott Dibble, because, I thought, well, wait, and we're not talking about bike paths here on roadways. That's, that's a different committee. So we could. Thank you, members. There's a A2 amendment that's sitting in front of our committee, and it's a simple amendment that it just clarifies the letter, or the number 180. The 180 catheters are the minimum, not the max permitted under insurance plans. It was a technical typo fixie thingy.
Senator Hoffman moves the A2 amendment. All those in favor, please signify by saying aye.
Aye.
Any opposed? The A2 is adopted.
Thank you, Madam Chair and members. And this is a simple bill. It would make a huge difference for people that live with certain health conditions. Senate File 3926 would require a health carrier to provide health insurance coverage for intermittent urinary catheters and insertion supplies. Imagine that. People that need catheters to go to the bathroom. And that helps people, they empty their bladder. And that's usually because of either a spinal cord injury or a neurological condition, or live with conditions like spina bifida. People who use intermittent catheters might use them temporarily or for a lifetime. But if people who need intermittent catheters don't have access to them, they can die. There's actually some providers that say, well, you should boil them and reuse them again. Honest to God, I'm not making this up. Research shows that with proper sterilization, catheters can be used without increase of risk or illness. But how does a person really properly sterilize supplies while running errands to a grocery store, or going to a hockey game, or while at school? And so there's a limit to the number of catheters a person can have, and that limiting does that really takes away the ability to live a full and complete life, man. It forces people to reuse them, and it just does not make sense. So there's one mom I know, a 2-year-old who lives with spina bifida, and said this about their catheter insurance coverage. And it said, when our insurance company denied coverage for Merit's catheters, we were stunned. They had lumped catheters in the same supply category as bandages and gauzes, and Merit uses over 1,000 catheters a year, so they had to pay out of pocket for those. That's thousands of dollars in excess medical costs. So 180 catheters per month is an average supply amount prescribed to people who use intermittent catheters. And out of the 4 health plans that responded to the 62J evaluation, only one stated that 180 catheters a month would be a new requirement. So we're talking very simple here. And I want to thank Senator Mann. Actually, when I was gone, you presented this bill in Commerce, and I believe it passed without a problem. In your packet is the Commerce Department report of the evaluation of coverage, and then there's also a written testimony from the Minnesota Spina Bifida Association. So I think you're just going to lay this over. Can it go to the floor?
We'll have to lay the bill over, Senator Hoffman. Members. Senator Morrison.
Thank you, Madam Chair. Thank you, Senator Hoffman. I'm actually shocked that this bill is necessary. If you need intermittent catheters, you need intermittent catheters. It's kind of a part of daily life. I am wondering if there is a fiscal note associated with the bill?
No.
Senator Hoffman, I believe there's one been requested, but we haven't received it back yet.
Yeah.
So.
So the answer is no.
Okay.
And if not, I think we could find the money somewhere. It should not be, I mean, to this, thank you, Madam Chair, but to that point, Senator, Doctor, it's just absolutely, it's like, which hand is the rock, right? Where's my, which hand is the rock when it comes to this stuff? And I appreciate your comments, so thank you.
Any other member questions or comments? Seeing none, Senator Hoffman, any final thoughts?
Madam Chair and members, thank you. It's common sense. Let's get her done.
It does seem very practical. And with that, Senate File 3926, as amended, is laid over for possible inclusion in an omnibus bill.
Thank you, Madam Chair, members. Am I staying here or am I coming back?
I believe so, yes. We will move now to Senate File 2342. That is acupuncture and herbal medicine practice provisions, modifications.
There's an A2 or A3 sitting in front of you, Madam Chair and members. That's the amendment that reflects the suggestions from the Board of Medical Practice.
Members, Senator Hoffman offers the A3 amendment. All those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? The A3 amendment is adopted. Senator Hoffman.
Thank you, Madam Chair and members, and I think Dr. Nick Doherty is going to come up here too and have a chat as well. But the amended updates, the acupuncture license language and statute that has been pretty much untouched since it was first enacted in 1997. For those of you that are looking at the calendar, that's 3 years after Senator Bobby Joe Champion was nominated for a Grammy Award, not that I'm counting. But first and foremost, the bill follows this national trend that removes the offense nomenclature from statute and renaming the practice acupuncture and herbal medicine. The language clearly defines the practice of acupuncture and herbal medicine, providing explanations and definitions of techniques that acupuncturists are trained in, and the newly amended language is reviewed by the board, and there is the Board of Medical Practice. And the Board of Medical Practice voted unanimously to support the new language. And so Dr. Nick Doherty is here, Madam Chair and members, and I just want to thank Senator Liskey, Abler, and Kupek for being co-authors. There's room for one more. If there's another doctor that wants to get on it, that would be nice. So thank you, Madam Chair.
Thank you, and welcome to the committee, and please state your name for the record and begin your testimony.
Thank you, Madam Chair and committee members. My name is Dr. Nicholas Doherty, and I hold a clinical doctorate in acupuncture and herbal medicine, and I'm a practicing licensed acupuncturist here in St. Paul. I stand before you today as the legislative chair for the Minnesota Acupuncture Association, and that is Minnesota's professional association for licensed acupuncturists. In addition, I'm the vice chair of the National Certification Commission for Acupuncture and Oriental Medicine. We thank you and Senator Hoffman and co-authors for allowing this bill to be heard. As Senator Hoffman mentioned, our scope of practice has been not touched in substantial ways for many decades, certainly longer than I have been in practice at this moment. Much of this, the language that you'll see within the bill is meant to remove some of this potentially offensive language. The term Oriental was stricken from federal bills back in 2016, and much of the profession of licensed acupuncturists has followed suit. To that point, furthermore, many of our national organizations have done so by renaming the profession, which doesn't alter the practice of the profession itself, of the medicine.
Perfect.
Within that, you will also see, as Senator Hoffman mentioned, we did consult with the medical board, our licensing regulatory body, to come up with some language that you see in the amendments that we feel still speaks very well to the bill itself, the education, training, and specialty of licensed acupuncturists in Minnesota. And I am here to answer any questions, should there be any. Thank you.
Thank you. Members, any questions or comments? Senator Abler.
Well, just to commend the bill and acupuncturists, they have, it's actually, it's one of the oldest methods, and America was slow to pick up on it, and we always want to analyze everything, and so, but it's remarkable. I don't know why it's insurance should all cover it. It saves money, it gives outcomes. Some of the results are just phenomenal. I just want to comment on the amendment on line 1.6 to 1.8. So the belt and suspenders, like, provided that when results fall outside the education, training, expertise, they're going to do a referral. Hello. That's what people do that have professional licenses. So, it's in there. It's almost offensive, but it's there. And so we're all part of a grand compromise to keep everybody happy about it. But if anybody, it should be more included as a primary first stop than it is. And so, anyway, good luck with the bill. I hope it can get done.
Thank you.
Thank you. Other members, questions? Senator Mann.
Thank you, Madam Chair. I just had a question on line 5.7. So this is under the scope of practice of acupuncture, and 5.7 includes the word bleeding. Can someone just explain to me what that means?
No.
Dr. Doherty.
I'm so sorry, Senator Mann. Could you repeat your question? I apologize.
Yeah, so under the scope of practice of acupuncture, that starts on the page 4, it goes into page 5, and on line 5.7, it says the word bleeding. So it starts on 5.5, the stimulation of acupuncture points, area of the body, substances in the body using acupuncture needles, heat, cold, color, light, infrared, violet, laser, sound, vibration, pressure, magnetism, electricity, electromagnetic energy, bleeding, suction, and other devices. What does bleeding mean?
Dr. Doherty.
Yes, thank you for your question, Senator. I'll be happy to clarify that. So there do exist within the practice of the traditional medicine techniques that do elicit small amounts of blood, percutaneous blood, from the patient to alleviate certain conditions such as pain, headaches, and things. These are exceedingly small amounts. We're talking 2 to 3 droplets of blood to do that kind of thing. There are other practices that could involve slightly more amounts of bleeding, but these are all in controlled settings, and these are not large amounts of blood that are taken from the patient in these ways. So small amounts of say, basically what's called a 3-edged needle that is used to pierce the skin of a patient, and no more than a few drops of blood generally coming out.
Senator Mann.
Madam Chair. So, it sounds almost like bloodletting, right, which is a technique that physicians used many, many years ago that now, there is no science behind it. Is there science behind that?
Dr. Doherty.
Thank you for your question, Senator. I can't tell you necessarily about that particular practice itself. This is generally done, as I said, and there is research behind some of these practices. For example, a technique that I've used is just to prick the tip of the ear, which can alleviate small headaches that are due to different conditions such as underlying hypertension and things like that can be effective. But I can't comment on the techniques that you're talking about.
Senator Mann, did you? Members, any other questions? Senator Hoffman.
I just wanted to make note that there is a letter of concern to HHS about one piece of the acupuncture bill from the doctors that is completely addressed by the author's A3 amendment. So, and that was about that injection language. So I didn't know, you educated me something on that, but I know across the board that there doesn't seem to be any concern from folks, and hence is a note I got from a former deputy commissioner and a former commissioner. I can out that person if you'd like, but, you know, I won't, so thank you.
All right. Thank you, Senator Hoffman. Any other final thoughts or comments? We will lay this bill over and for consideration, but.
Come on, give me one, please. I'm kidding. Thank you, Madam Chair. I'm just giving you a hard time. You got a
Senate
lot
file
to do.
2342 as amended is laid over for possible inclusion in a future omnibus bill. And Senator Hoffman, you have one more bill, the Senate file 4864.
Thank you, Madam Chair and members, and we get to call Matt Burdick down to hang out with us for this one, believe it or not. So there he is. Do you realize he would not come down once in our hearing yesterday? Every time we turn around, we just looked at him, and it was right. So we just kept getting the thumbs up on the 22 amendments. So, Madam Chair and members, this is similar to Senate File 3936. This is the direct care and treatment recodification bill. The Senate File 4864 is the reviser's cleanup bill. So remember what we had to do? We had to find language like here within, here without, I mean, and change that. So the language is removing the portions that already expired according to Section 256, Subdivision 42, if you guys want to pull out your books and look at that. But the expired reports were compiled by the department, and Mr. Burdick is here to answer any questions or get in the weeds on people, so.
Thank you, Senator Hoffman. Mr. Burdick, did you?
Thank you, Madam Chair. For the record, Matt Burdick with the Department of Human Services. Thank you, Senator Hoffman, for carrying this legislation. As the Senator indicated, this is a bill that comes forward with the Reviser's Office. Just for historical context, there was legislation passed, and much appreciation to the legislature. This is a Senate-led initiative that allows for the expiration of ongoing legislative reports. Requires DHS to fulfill a different report where we provide a list of reports that will be expiring to the legislature, and that is published each January to give the legislature a chance to consider if there are reports that continue to have value. But we really appreciate this because it allows us to focus our work on things that are perhaps more pressing and of more direct interest to the legislature.
Thank you. I do have, we heard this in your committee, Senator Hoffman, and talked about that there were a few items that were applicable to the jurisdiction of the HHS committee, and that's, you know, why it's here today. I did have an amendment drafted because I do think I'd like to have more conversation about three of the elements, the report on the interagency agreements and interagency transfers, and then there's a couple other reports that are included in the repealer that have to do with the homeless youth report, and then there's a high-risk pregnancy report. And I think at the hearing, Mr. Burdick, you talked a little bit about why you thought that that those might not be needed, but I guess I'd like to have a little more discussion about that before we remove those. So I don't know, Senator Hoffman, if you'd be willing to offer the amendment, or I can have Senator Mann offer.
So be it. I think this is why we exist. I mean, if you've highlighted some things that have some concern, I mean, it's the right conversation. It's like yesterday. So I'm fine authoring any amendment you have there, Madam Chair.
Okay. Senator Hoffman offers the A1 amendment. Members, like I said, it just takes out those from, or excludes those from being repealed, and puts in language that would have them continue on. And I will continue to have discussions with DHS about these reports. Mr. Burdick.
Thank you, Madam Chair. If I may, just in reviewing this report, and appreciate this and willing to obviously engage in further conversation. Just on each of these, if I could briefly, would love to understand more about what the legislature is looking for on this interagency transfers. Obviously understand the need for the legislature to have transparency on things that happen in between sessions, and just want to talk about how we can fulfill that request in a way that's getting you the information in the most efficient manner. On this second piece here, this was related to, I believe, to our conversation around a pilot project that's now kind of a more formal part of our ecosystem, the integrated healthcare for high-risk pregnancies. This is actually a new report that's come into play more recently that does a more comprehensive look at this. And I think we do see value in this report continuing, since it's something that's a newer initiative. So just want to say, I think we have some alignment there. And then on the homeless youth report, we would love to talk about maybe refining what goes into this report and other alternative means of maybe getting you some of this information. A lot of the information in this report is actually done much better by the Wilder study, which I believe was just recently published, as well as HUD's point in time count. And so we don't want to be duplicating those efforts, but what those, the one piece that those reports don't capture is maybe specific information on grantees. So we'd just love to entertain how we could get that information to you all in a way that gets you what you need, but also doesn't create extra work for the department. So appreciate the conversation.
Thank you. Yeah. Senator Hoffman, did you?
Thank you, Madam Chair, and I'm glad Mr. Burdick brought up that the Wilder Foundation, the report, they have 1,000 volunteers go out and they do this. Just it absolutely shows what homelessness is happening in Minnesota, and at the intersectionality of intellectual disabilities, developmental disabilities, substance use, and mental health. It's absolutely worth us investing into keeping that going somehow. And I just, that what propped that was what Mr. Burdick said. The other piece, Madam Chair, is our Title V people have an obligation on the perinatal and prenatal side. So do our early intervention services people. And so I'm glad that you highlight that piece of it that has to be there, because we do have an obligation in our health outcomes with the Department of Health to make sure that the perinatal, prenatal stuff is looked at. And so I'm glad you keep this conversation going, Mr. Burdick, with the good chair. So thank you, Madam Chair.
Thank you. So I guess in that spirit, I'd like to adopt the amendment, and then we can keep talking about how we can refine the language to get it closer to what is useful for both us and for the department. So Senator Hoffman offers the A1 amendment. Members, all those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? The amendment is adopted. Thank you. Any other questions or comments about this bill?
Can it go to the floor?
Let's see.
I'm
Well,
kidding.
I was going to ask you, Senator Hoffman, would you like it returned to your committee for consideration?
It's Madam Chair and members, I think yesterday our work, I think it's already placed in our omnibus, if I'm not mistaken. And so, yeah, you can return it to us, or you guys can keep it. I don't care.
We could lay it over, and then we can work on the.
Yeah.
That might be easier for me to keep track of that. So, okay.
Awesome.
Senate File 4864, as amended, is laid over for possible inclusion in an omnibus bill. Thank you.
Thank you. We still have to go through this. Thank you, Madam Chair and members.
Next up, we have Senate File 4946. Madam Chair, whenever you're ready.
Thank you, Madam Chair. First, I have Senate File 4946, and this is a bill that addresses an area that we've talked about in committee about trying to find ways to address the healthcare workforce and shortages that we see across the state and in many different healthcare professional disciplines. Part of our support for training and medical education comes through academic health partnerships, and they're vital to a strong training pipeline. And we make many significant investments at the state level, and these are important. So in order to take steps to kind of accelerate closing gaps in filling positions in these fields, we'd like to look at innovative ways to increase funding, as other states have done with additional federal funding mechanisms. This came up as part of the U of M Academic Health Task Force. The importance of graduate medical education was discussed, and the possibility of improving federal funding levels was brought forward as one of the final recommendations. Recommendation 19 was maximizing federal drawdown of GME, Medicaid, and Medicare matched funding. In this bill, stakeholders have worked with DHS and with Senate Council to come up with language to help us try to draw down additional federal funding, and additional work is ongoing to incorporate feedback from the Department of Health. I do have testifiers here today who can speak more in more depth about what this proposal would afford for Minnesota.
Madam Chair, would you like to adopt the A1?
Oh, yes, I would.
A1 is an author's amendment. All those in favor signify by saying aye.
Aye.
All those opposed? The amendment is adopted. And to your testifiers, we have Dr. Kelly Frisch and Dr. Rachel Sauls. If you can come down to the table. Dr. Frisch, please introduce yourself and proceed.
Madam Chair and Senators, my name is Dr. Kelly Frisch. I am a primary care physician with 25 years experience in practice. I'm here today in my role as the current board chair for the Metro Minnesota Council on Graduate Medical Education, or MMC-GME. This is a coalition of Minnesota's teaching hospitals and graduate medical education programs, including Health Partners, Hennepin Health, mHealth Fairview, the University of Minnesota, Allina Health System, Children's Minnesota, Centra Care, and Essentia. Thank you for the opportunity to testify in support of Senate File 4946, which creates a new funding stream for graduate medical education. GME is the required training for physicians after the completion of medical school to become licensed physicians or specialists. GME training includes residencies or fellowship programs and can range from 1 to 10 years in duration. Minnesota currently funds GME and training for essential non-physician health professionals through the Medical Education and Research, or MERC program. MERC receives approximately $59 million per year in total funding from state and federal Medicaid reimbursement, funding that has been flat for nearly a decade. Committee members may recall hearing about MERC last session. Due to changing federal requirements, MMC-GME, DHS, MDH, and the legislature partnered to restructure the program. However, this was not increased funding for teaching hospitals, and in fact, likely resulted in a state general fund reduction relative to 2002 and prior year state commitment to GME. Chair Wiklund's bill does not eliminate MERC. Rather, it leverages additional opportunities for federal matching support for GME. This means not only increased funding for GME, but the ability to repurpose MERC to support and expand opportunities for non-physician health professional training. Just a few days ago, the committee devoted significant time to discussions about hospital funding, so I will not rehash those details. However, GME is yet another program that is paid at well below cost. Teaching hospitals, which are also often safety net hospitals, cannot make strides in addressing the physician shortage with current funding and cannot divert resources away from patient care. We all share the goal of ensuring that Minnesota remains a leader in medical education, innovation, research, and care. However, after decades of flat funding, we're in danger of falling behind. Many other states spend 50 to 60% more per capita in support of Medicaid GME as compared to Minnesota. Minnesota's GME spending is about $10.30 per person. Virginia, $16.50 per person. Michigan, $16.20. Arizona, $15.80. New York spends nearly 9 times more than Minnesota on GME per capita, or $89.10 per person. The funding is critical for many reasons. Well-trained physicians lead to high-quality outcomes for patients. Supporting GME for specialty and primary care ensures a future workforce for the state of Minnesota. In 2022, Minnesota's teaching hospitals trained approximately 2,500 residents and fellows, and 72% remained in Minnesota for practice. GME requires a healthy infrastructure for innovation and a culture of inquiry. GME is expensive. Costs of accreditation and salaries differentiate it from other health professional training. Additional funding is needed to expand GME to improve our physician shortage. We need sustainable funding to support this work that does not draw from patient care resources. As Senator Wiklund mentioned, the governor's task force on the University of Minnesota Academic Health Center endorsed this concept with 93% support. To maximize the use of Medicaid funding to support health professional education, and specifically to maximize the federal drawdown for GME, Medicaid, and Medicare matched funding. The new distribution formula proposed in Senate File 4946 is supported by all of the Metro teaching hospitals, as well as CentraCare, Essentia Health, and Mayo Clinic. Thank you for support for this critical, important investment in our state's healthcare workforce.
Thank you, Doctor. Next up, Dr. Rachel Sauls.
Good morning, Madam Chair and Senators. Thank you for the opportunity to testify in support of Senate File 4946. I'm Dr. Rachel Sauls, current Chief Resident in Internal Medicine at Hennepin Healthcare. I'm originally from Roseville, and I'm a second-generation University of Minnesota Medical School alum and Hennepin-trained physician. My mother completed her internal medicine residency at then HCMC in 1991, and both of my sons were born at Hennepin during my training under the care of residents. I care for patients hospitalized with acute illness and have a special interest in the care of older adults, ensuring smooth transitions of care, a critical crisis point in our hospitals. I will continue my work in graduate medical education this summer as I join the hospitalist group at Regents Hospital. I'm here to testify personally about the vital need for additional state and federal investment in graduate medical education, both for the current and future of our healthcare delivery system. If you are worried about health equity, please invest in GME. When Medicaid pays for the full cost of training and residency, it best invests in health equity for the next decades. Among my colleagues, residents are increasingly culturally competent, language proficient, and diverse. We, the next generation of physicians, reflect the rapidly changing demographics of Minnesota, the United States, and the international community. Just last week, we welcomed the incoming class of 2027, a group of bright and humanistic doctors arriving from medical schools both blocks and continents away, who speak Spanish, Somali, Arabic, Portuguese, French, Urdu, Hebrew, and English, to name a few. If you are worried about the rising costs of healthcare, please invest in graduate medical education. Ensuring an adequate physician workforce is key to access, prevention, primary care, and post-acute transitions. I spent 9 months of my 2 clinical years in medical school as a part of the Rural Physicians Associates program, caring for the underserved of Western Minnesota. I carry with me the stories of 10 older adults who partnered with 15 local third graders in an intergenerational pen pal program, combating the deep social isolation and loneliness of the rural older adult population, an additive risk factor for mortality which rivals tobacco use. Only through the knowing care of their primary provider, my preceptor, was I able to recruit them for this community building experience. If you are worried about rural gaps in healthcare access, please invest in GME. It is a simple fact that physicians trained in Minnesota are much more likely to remain here for their careers. My classmates and I, in the last months of our program, celebrated the signing of our colleague. Born and raised in northern Minnesota and a University of Minnesota Duluth graduate, he accepted a position as a full-time hospitalist in his hometown. What spread faster than the news of his employment was the snapshot of the massive billboard posted outside the Rural Access Hospital, which welcomed him home. His community had invested in him, and now he returns on that investment 100-fold. Lastly, I would like to bring to your attention the letter of support from Dr. Megan Walsh in your packets. Not only has she been a profound personal role model and fan favorite lecturer, she served on the governor's task force for the future of academic medicine and has dedicated her career to ensuring learners have access to world-class education opportunities at Hennepin. She wishes she could join us to testify to the importance of this proposal. Thank you for allowing me to testify on this critically important legislation, and I'm happy to respond to your questions.
Thank you, Doctor. Members, we do have Richard Toner on Zoom. He is the Administrative Chair in Government Programs at Mayo, if you have any questions. Questions or concerns? Seeing none. 4946 will be laid over for possible inclusions. Next up, we have Senate File 4912. Madam Chair, when you're ready.
Thank you. Thank you, Madam Chair. As you will recall, committee members, we had a discussion back in February where the chair of the U of M Academic Health Task Force came and presented the findings and kind of gave an overview of the task force report. Chair Malcolm laid out how we got to the recommendations of the task force and kind of the thought process that went into that. And she laid out some particular findings I'd like to highlight, that the U of M has uniquely comprehensive capabilities across the health sciences schools. And another key thing for Minnesota is that we have an unusual breadth and depth in healthcare capacity in our state. And we can look forward to better results if we are encouraging even more partnerships with the University of Minnesota to leverage all the assets that we have in the state. Senate File 4912 is related to recommendations from the task force report. And I guess at this point, I would like to adopt the amendment, the A2 amendment.
Motion is to adopt the A2 author's amendment. All those in favor signify by saying aye.
Aye.
All those opposed? The amendment is adopted.
So when I was working, thinking of ways that I could bring some of the ideas forward from the task force report, the university also approached me with the underlying base bill that you saw, and we discussed whether there'd be an opportunity to combine those. And so the resulting amendment that we just adopted basically has three parts that address different areas of the task force recommendations. One is to improve collaboration between the University of Minnesota and the legislature. Part of the task force findings were that perhaps more collaboration, more oversight by the legislature would help us to understand how appropriations are being used and how we can ensure that the goals laid out by the university are also in alignment with population health and other goals that we might have for Minnesota. We also talked a lot about workforce planning and development, so there's a section on that. And then lastly, the bill lays out the U of M vision for specific programmatic purposes, and taking from the language of the base bill. So just briefly, the section 1 is a way to help the legislature better understand appropriation requests that relate to the health sciences programs. That would require some written reporting that the university would bring forward to us so that we know kind of what the requests are, how they're planned to be used, what are the goals and outcomes that we would like to have from those appropriations. There would also be another report that would be an annual report that would help us over time to understand how the appropriations are being used in the health sciences area, and how different performance measures are being met, so that we can understand better about whether we're getting closer to our goals, goals and outcomes that the university has and we have as a state. Section 3 of the bill is a direction to have the Department of Health develop a report with recommendations on how to establish health professions workforce advisory council in collaboration with the University of Minnesota and also Minnesota State. During the task force, we talked about that we have a lot of data about different health professionals and the shortages that we might be seeing in different places. We don't have an entity that necessarily coordinates and formulates recommendations for us about how we might be better addressing workforce shortages and applying different solutions. So that's what that section relates to. Section 5 is the appropriations based on the University of Minnesota's academic health proposal, and that section lays out the programmatic thoughts that the university has for a requested $80 million to go towards different areas of funding. And so I do have a testifier here. Dr. Tolar is here to provide some additional thoughts on this from the university.
Dr. Tolar, please introduce yourself to the committee and proceed when you're ready.
Morning.
Madam Chair, members, I'm delighted to be here today. My name is Jacob Tolar. I serve as a Dean of Medical School and Vice President for Clinical Affairs at the University of Minnesota. I am truly grateful for everything that I've heard this morning, and I know about you and your portfolios. And right away, I'd like to say that I fully support the previous bill, and the training and access and workforce is one of the remarkably important parts of the ecosystem of healthcare that we have to, are obligated to deliver on behalf of our fellow Minnesotans. I'd like to thank Senator Wiklund, of course, for her work on this amendment and her work with the task force. The task force that met in this room, mostly, has been an impressive gathering of goodwill and good minds, and had an important task that had to be accomplished in a relatively short time. We are deeply grateful to everyone who participated, the time and experience that created important recommendations and helped shape a path forward for this critically important portion of the future of the state of Minnesota. The task force had a call to action, which I like. I like when things are done, to the university. It calls for us to align ourselves in a more planful way with the state and to partner more thoughtfully and thoroughly with you, with the legislature. And we agree. It calls for more collaboration across the ecosystem of healthcare, and again, we agree. It calls on the University of Minnesota to lead in advancing and expanding the high-quality care through innovation to produce well-equipped health workforce in partnership with all the health science schools, with partnerships with all the healthcare systems and everybody else in the healthcare ecosystem. And again, we agree. The issues that we care about are the same that you care about. It's access, it's equity, it's innovation, it's quality of healthcare. We share these goals with the legislature, with the state, and with the other health systems. Now, this amendment and the reporting language will help guide us further in that direction. Ultimately, the task force report presented a significant opportunity to envision what's possible for the health of all Minnesotans. It stated that all the health science schools and all of the health systems play an important role in health of Minnesota, and that we can do more to leverage, to amplify, to coordinate and synchronize all these strengths towards the collective action for patients in Minnesota. And again, we wholeheartedly agree. Madam Chair and members of the committee, we strongly support Senator Wiklund's amendment, and thank you for your time today, and thank you for making our lives better. Madam Chair.
Thank you, Dr. Tolar. That is the end of our list of testifiers. Members, questions? Senator Aki.
Thank you, Madam Chair. And just, Senator Wiklund, on this one, there's part of this has got policy in it that would give us some additional information and such that looks good. I also, of course, we see the large costs. At this point, would that be something you might separate and take the policy out of this bill if need be to at least move that forward? I just was kind of wondering what the plan was for this.
Senator Wiklund.
Thank you, Madam Chair, Senator Utke. The plan right now is that I believe this bill, we're going to pass it to higher ed because the different language refers to things that the higher ed committee would want to examine. I think at that point, then we'll have a discussion about, what could we move forward this year with, given more information about, what the budget targets will be and so on. But my hope is that bringing this forward is that we do establish some of these collaborations in terms of getting access to information and planning for future activities, that we can get started with those this year. So I'm hopeful that, we can try to move everything forward, but we'll move the things we can, because I do think it's important that we get started.
Senator Utke. Anybody else? Senator Morrison.
Thank you, Madam Chair, and thank you, Senator Wiklund, for both of these bills. I think they're critically important. I want to thank the earlier testifiers, the doctors. I didn't get a chance to thank you for being here, and thank you for your service to our state and your family's service to our state and our patients. I was surprised to learn that Minnesota lags in per capita spending in graduate medical education. I think that's an important statistic, so I appreciate your elevating it. Dr. Tolar, it's an honor to have you in committee this morning. Thank you for being here. I'm a proud co-author of this bill, and I'm grateful to Senator Wiklund for her leadership. Minnesota has been a healthcare leader for a long time, and we're kind of at a moment, kind of a watershed moment, and we face a real opportunity here, and I think this bill will help propel us forward if we're able to adopt it. Let's continue our tradition of medical excellence here in Minnesota. So thank you, Senator Wiklund and testifiers.
Senator Abler.
Thanks. Yeah, we had a little discussion about this topic when the report came out. And so, this is a bunch of words on paper, and they're nice words, and we've asked you and other people for more reports on more things. Sometimes we read them, sometimes they advise policy, and sometimes they're effort that people exert. We chatted Dr. Tolar and in my comments before. I'm an author on this too because I want to promote this project. I think Senator Wiklund has taken a pretty good stab at it. But I look at this and I've said at the end, what are we going to get out of this? And so I've encouraged the you actually on their own to be the you, to them be the developers of policy, to them be the visionaries. They train the bulk of the doctors in the state and many other professions. And I don't think our health system is doing that well in Minnesota. I think it's retrenching. We're being run by, this is not meant to be political, but we're being run by corporate decision-making, not by policy decision-making. We continue to fund a greater percentage of people by state and federal funding, which is actually working to collapse some of the very institutions that we want to have. In today's paper, North Memorial is laying off 113 people, including some pretty important, like they're not having just the ordinary neonatal, but not the complex one. Who's going to do that? And so I think with visioning that the you could do, I don't know how you put that on paper, but somebody needs to figure this out, and I can tell you the political process is not making it work. Single payer, not single payer, for-profit, not for-profit. Those are fine. But if we move to any one of those things, we're still going to face the economic challenges. And I think, as I mentioned before, I think if Dr. Tolar and others would convene a bunch of people that would be happy to come. I asked one well-known person on the topic, and they said they'd be happy to go if you buy them lunch and pay for parking. And just convene them together and start creating any number of commenting individuals, retirees who have had 30, 40 years in practice, who would love to take that knowledge. And we met some young doctors today, bring in some of them, and some of the corporate executives and whatever. But I think we're really lacking for a vision overall. And we have a piecemeal way that we go about setting our policies. Case in point was last year's bill, and we established some statewide policies on healthcare that were done. I don't even know what they are. I don't understand the bill. They were a hybrid of stuff, and I'm sure Senator Wiklund understands, and maybe Senator Liebling does. But I think as we set policy, we want to be wiser than that and more inclusive. And so, if this bill gets us there, then I'm all for it. But I think I just want to encourage you to truly be that, we overuse the term North Star, but I mean, I think that regionally, the U is the most amazing thing in the multi-state area, and just encourage you to go that way, whatever we put on paper. And we all know there's not money to fund this, so I signed the bill knowing there wasn't going to be money. But I think the U has quite an endowment, and they have some dollars they can use for operationally putting some of this kind of stuff together. So I encourage, if this is the means to that, then I'm all for it. And as it gets worked through the process, and I'm not sure if I'll be on the conference committee or not, there's some things in the bill I don't think I can absolutely vote for. On other policies that I wish we wouldn't put into bills on very controversial matters. But this is really important, and I'm happy to be part of that process in any way I can. And these words now are meant to encourage the author, who I have a great deal of respect for, and Dr. Tolar and other people at the U. So anyway, good luck to you, and if I can help, let me know. Thank you very much.
Dr. Tolar.
Madam Chair, Senators, I am deeply grateful for your comments. I do agree with Senator Morrison that that Minnesota has been the leader in healthcare. For me personally, I came here 30 years ago from Cambridge, England, because University of Minnesota was the leader in my field. The whole field of pediatric oncology, which is my day job, started here. Cardiovascular, you look at the med tech around the state, started here. Very many advances in infectious disease started here. We got what it takes. We have the people, we have the skills, and we have the will to do that. I agree with Senator Abler that, pardon me, that there are challenges in articulating the clear vision. It's actually not that complicated. To your comment, Senator, the business of healthcare in the United States is very different from clinical care in the United States. These are very different things that overlap, for existential reasons, but they are not operating on the same way. Senator Wiklund's bill works on the clinical care. The vision for this bill and the vision for University of Minnesota Health Sciences is save hands in Minnesota. That's it. It's actually not that complicated, and for that we need the innovation, which is in the amendment. We need to work on the underserved population access and quality. We need to have workforce development. We need to do better in the primary care, both close to big cities and big hospitals and in greater Minnesota. And we have to use the novel technology, including AI and machine learning and so forth, to develop better care models for people in Minnesota. That's it. That's what it is. And I can assure you from my clinical practice and from the service that I have been honored to provide to the university that the odds are great, the margins are small, and the stakes are infinite today. Thank you, ma'am.
Thank you, Doctor. Senator Abler.
Just briefly. So I appreciate the discussion, and I just want to, I know we're out of time today, and we could spend 2 hours talking about this, and it would be productive, but I'm not going to do that. But I want to push you a little bit, Dr. Tolar, and the advocates for this bill. The business of healthcare determines what healthcare becomes. So you have great safe hands, but at Mercy and Anoka, you're not going to have very few pediatrics going on because of a corporate decision. And I think that's on a profit-minded side. North Memorial is closing departments on a survival side, and HCMC and North Memorial, which serve many people who are greatly at risk, are trying to stay open as they go about their gap and their business. And so somewhere, maybe I'm just being optimistic, but could there be somewhere where there's a non-political, does people decide just on a policy basis what might make the most sense, and then offer us some insights about that and see if the political system can handle it. But I can tell you all the Obamacare, not Obamacare, all the improvements, we've got to do something, and that's what brought the ACA to us. Have to do something, said Representative Huntley. And now we're here today, we have to do something. And so in 5 years, we have to do something again. And so I'm just urging you for all the king's horses and all the king's men and queen's horses and whatever, that you could convene. Somebody has to guide this thing, and I don't think that any political figure is able to do that, whether Republican or Democrat or, marijuana party. So anyway, thank you very much.
Thank you, Senator. Senator Wiklund, any final thoughts?
Yeah, I just would add, I really greatly appreciate Dr. Tollar's testimony today and bringing forward the U perspective on this, and I look forward to working with them further and the Department of Health on this bill. And also just want to say that this is my attempt to help us bring forward these recommendations in a way that we can work on them in the legislative process this year. I think it is going to take, a combination approach with the university working in the ways that they can independently of the legislature, and we are all going to have to step up and contribute to trying to make this vision a successful one. So I appreciate your time and the conversation today. So thank you.
Thank you, Madam Chair. The motion is for Senate File 4212 as amended, 4912 as amended, to be recommended to pass and be re-referred to higher education. All those in favor signify by saying aye.
Aye.
All those opposed? The motion prevails. And with that, we are adjourned.